Good evening, everyone, and welcome to this ERN-EuroBloodNet topic on focus on inherited platelet function disorders. We are at the second session of this webinar series on a topic on platelet aggregation, investigating a suspected platelet function disorder with the collaboration and the presentation of Dr. José Rivera. Next slide, please. Before starting this webinar, I would like to remind some housekeeping notes. So your microphone will remain muted during the presentation. Please note that this webinar is being recorded and that the record of this webinar will be published on our Edu Academy platform on YouTube after the webinar session. And I would like to highlight that you can submit your questions via the Q&A chat box at any time. You will have a dedicated session of Q&A after the presentation of Dr. Rivera. I would like also to remind that this webinar is CME accredited. This program is accredited by the European Board of Accreditation in Hematology, EBA. You can earn 1 credit per webinar attended. To receive your credits, just attend the full webinar, complete the feedback survey at the end that you will receive by email, have an active EBA account as well, and use your EBA email in the survey that you will fill in. For the instruction, you will receive this an email after this webinar. Next slide, please. I would like also to highlight that this webinar session is empowered with the Zoom AI translated caption. So you see how to use it. You just need to check on the caption settings of Zoom and choose English for the main language of the session, and then choose the translated languages. Next slide, please. So you have here the agenda of all the 13 sessions of this cycle of webinars. So we are at the second one. Don't forget, the next one will be on the 17th of December 2025, and you will receive the link for registration after this session. You can scan the QR code that you see here if you want to connect to the ERN website and registration lists. So I just like to let the floor to Professor José Rivera. Professor José Rivera Pozo is from the Blood Transfusion Center of Murcia and the University of Murcia. He is a leading expert in platelet physiology and blood processing with over 150 publications and extensive international collaboration. So, Professor, the floor is yours. Thank you very much.
Pepe, the microphone is muted. Oh,
now,
excellent.
To start, I really like to thank the organizers of this webinar for the kind invitation to participate in this series and to talk about essentially my experience in platelet aggregation. Right, so I have no conflict of interest regarding this talk. And these are the learning objectives. I will give a short overview of the inherited platelet function disorder, about the principle and recommendation for performance and interpretation in the diagnosis of inherited platelet function disorder of the LTA, and then examples from our casuistry about using and interpreting the platelet aggregation experiment. So inherited platelet function disorder is a subtype of the inherited platelet disorder. And these are an heterogeneous group of rare diseases that probably are about 15 different ones that are caused by abnormalities in about 30 genes. And as I said, it's a part of the more than 60 types of inherited platelet disorders. These disorders are caused by alteration at the level of the platelet receptor, either for a receptor for adhesive proteins, soluble agonists, or enzyme signal transduction pathways, or granules, or even membrane phospholipids. Of course, these disorders have a clinical impact because the affected patient can bleed. Some of them might also be related to blood malignancy, and some also are syndromes, and might be associated with extra hematological disease, as happened, for example, with lung fibrosis in the Hermansky-Pudlak syndrome. The real prevalence of this disorder is not well known. It can be estimated within 1 in 10,000 to 1 in 1 million for the more severe. But certainly, they're probably likely underdiagnosed. And recent studies have shown that more than nearly 6,000 new diagnoses are made annually. And based on recent DNA sequencing data, the estimation can be even 0.3 to 2.5% of the population. So we've been interested in these diseases for a long time, all my career. And because of that, in 2008, we launched this multicentric project of functional and molecular characterization of inherited platelet disorders in Spain, that leads to the creation of what we call the Grupo Español de Alteraciones Plaquetarias Congénitas, or GIA. So this is now being coordinated by me and Professor José María Bastida in Salamanca. And this scheme shows how we work. We receive a proposal for studying patients from anywhere in Spain. We review the clinical and laboratory data with the physicians proposing the patients. Then we try to get blood samples from the patients, perform a full platelet phenotyping study. Also, always we try to do a molecular or a genetic study to get a genetic diagnosis, provide a final report to the physicians so they can use this information for the management of their patients. And we also try for the confirmed cases to enroll them within the Spanish registry of inherited platelet disorder, or red plaque. So in these years, we have collected around 500 different cases of inherited platelet disorder, 45 different types. And among those, about 155 are inherited platelet function disorders, representing 19 different types as shown in this slide. So how we approach the diagnosis of these disorders? As recommended by the international societies and many experts in the field, we follow this flowchart, starting with the clinical evaluation and the preliminary test that I think will be reviewed by Professor Gressel in session 3. Then we perform the laboratory analysis that will be reviewed in different sessions in this webinar series. And as I said, we also address the molecular characterization of the patients, and something that will be reviewed in session 5 by Professor Kathleen Fresson. And I think we all can agree that because of the more widely use of the next generation sequencing of DNA, maybe the genetics diagnosis has been moved to the first steps of the diagnosis process. Because also we know that the genotype of the patients might also predict the evolution of the disease and can be critical for the correct management of the patients. Right, regarding the investigation in the laboratory, we have a battery of screening methods for diagnosis of inherited platelet disorders. Probably the best known is the PFA 100, but there's also new ones like the total thrombus analysis systems, the multiplate, which is an automatic test for performing aggregation in whole blood, or some viscoelastic tests. But these tests either have been shown with low specificity and poor sensitivity for metabolic platelet disorder, or still we have scarce information about the usefulness of these tests, like happens with recent TITAS system. And for diagnostic purpose of these diseases, the battery of tests is smaller, maybe, and include the light transmission aggregometry, which is the reason of this presentation. But we also use widely the flow cytometry, the electron microscopy, and some biochemical methods, including electrophoresis and Western blot of platelet proteins, or the measurement of substance within the granules, or second messengers like cyclin MP, or agonists like thromboxane that can be measured in either platelets supernatant from the platelet aggregation assays, or serum or whole blood. So this talk is focused in light transmission aggregometry in PRP, which is an old procedure that was developed independently by Gustav Bohr and O'Brien in the 60s. And the principle of the test, as you all know, is the measurement of the photometric measurement of the light crossing a suspension of platelets that will increase as the platelets aggregate in response to an agonist. So the change in the light transmission through this cuvette with the platelet suspension will be reflected in a curve like the one we can show here, in which we can measure the lag, say the time that takes for the aggregation to start, and also the shape of the curve that can be like this one for irreversible aggregation, be biphasic, as is typical from some agonists, like, for example, epinephrine. And we might have no response in the aggregation test as a consequence of, for example, the use of antiplatelet drugs, or in the presence of a severe inherited platelet disorder. So these are advantages and limitations well established for this procedure. Among the advantages, it is flexible. We can use multiple agonists and doses and get information of the different aspects of the platelet function, receptor, secretion, activation. But the test is measure a response that is a non-physiological response, is a non-physiological condition. It is time-consuming, require qualified personnel, and also require high volume of blood to perform the test, which is a limitation, for example, in a small child. Also, it might not be applicable in cases of severe thrombocytopenia, or, as I said before, in the presence of interference drugs or foods. And it is also influenced by many pre-analytical variables, including anticoagulant extraction, the way to make the PRP. So in general, it's considered to be a procedure poorly standardized. I'm not talking about this today, but we know that there might be alternative methods to measure platelet aggregation, including the aggregation, the measurement of the platelet aggregation in whole blood, for example, using multiplate, the aggregation measure in wells in a plate, which contain lyophilized agonists in the wells, or we can use even flow cytometry to detect aggregates with two different fluorochromes. None of these procedures have actually replaced the use of the standard platelet aggregation in PRP. One method that might in the future take this place is the automatic aggregation in the new coagulation analyzer, like the Sysmex series. And in fact, this was evaluated in UK in different centers with providing high sensitivity and specificity, and it was presented as an oral communication at the last ISTH meeting in Washington. So we focus in the light transmission aggregometry, and because the importance of this test and the widely and the being used worldwide, experts and scientific society has always been interested in making recommendations for the standardization of this procedure. And maybe the most important ones are those that were made in 2013 by the subcommittee of platelet physiology of the IPFDs. And I must say that these recommendations are now under review, and a group of experts will make an update of these recommendations. And this subcommittee has also made a recommendation recently, or will make recommendation for using this test in the setting of thrombocytopenic patients. The paper is now being reviewed. So the recommendation of the LTA by the IPFDs came from a survey that was made by Catania and co-workers with 7 different statement groups in different aspects: clinical usefulness, pre-analytical variable blood collection, preparation of the PRP, methodology, choice of agonists, and how to evaluate and report the results. And from that, they make this big recommendation regarding the control of the drug use in the donors or in the patients, how to extract the blood, the preparation of the PRP. An important one is to recommend that the platelet count should not be adjusted with platelet poor plasma, because that may force the or reduce the response of the platelets. It's important to run a normal subject in parallel with the patients, and the recommendation to complete the test within 4 hours from extraction, which is really difficult from my point of view. And they also recommend a battery of agonists and how to evaluate the curves. And I like to highlight an important thing, which is from this recommendation, which is the clinical usefulness of the LTA. And according to this recommendation, it is clinically useful only for the study of subjects with bleeding disorder, but not for identification of subjects at the risk of thrombosis or monitoring subjects on antiplatelet therapy. Maybe this recommendation can be reviewed nowadays, but I think that it should be, they still perfectly applicable. So the question is, how useful is the LTA for the diagnosis of inherited platelet function disorder? And the answer, or my answer to that question, is it can be very useful if we use it properly. To start, the LTA alone can be a diagnostic for a few severe inherited platelet disorders, such as Glassman thrombocythemia and Bernard-Soulier syndrome, because the pattern of aggregation in these 2 diseases, severe diseases, is quite typical. In the case of Glassman thrombocythemia, as you can see here, and you all probably all know, we will have a lack of response to most agonists or all agonists except ristocetin, because this antibiotic will agglutinate platelets through GP1B alpha by the binding of von Willebrand factor, and not by the making links between molecules of the alpha-2 beta-3 integrant between platelets. In the case of the Bernard-Soulier syndrome, it's the opposite, because, as I said, it's mediated by the von Willebrand GP1B alpha axis. And in this case, this is the ristocetin agglutination, or is what we will lost in this disease. In contrast, we can see at least some aggregation response to other agonists. But of course, the utility of the LTA in the diagnosis of mild and intermediate inherited platelet disorder is far less clear, and this has been reflected in many publications, as those shown in the slides. But maybe, and this is the purpose of this talk, we can have some cues or general guidelines to interpret this LTA in this moderate inherited platelet disorder. And for that, I will refer to this seminal paper that I have found really very useful in my clinical practice in our lab. And the study of Daboud and co-workers from the Steve Watson group, they performed lumigaggometry during 5 years in 111 unrelated cases. And using an extended panel of 9 agonists, they were able to classify 58 of the patients within these groups of platelet defects. And they provide some cues for being able to classify the patients within these groups. One of the most common one was the GI-like defect. In this case, the hallmark or the diagnostic feature in the aggregation profile was to see a lack or reduced response to ADP and adrenaline, in contrast to a reduced aggregation to low doses of other agonists and a robust response to arachidonic acid. Distinguish this from a defect in the thromboxane A2 pathway. The second most common group was the dense granule or secretion defects, 30% of the cases. In this case, the key diagnostic features in the LTA were the reduced aggregation to low concentration of most agonists, most notably collagen, as you can see here, but combined with a robust response to ADP, 10 micromolar, which seems to be consistent with the minimal role that the secretion of ADP can have in platelet aggregation in this case for this agonist. The third group, more common group, was the thromboxane pathway defect. In this case, the hallmark in the platelet aggregation is the lack of response to arachidonic acids and a reduced or absent primary wave to adrenaline, a reduced response to other agonists that can be recovered at high dose, except for the case of the ADP and adrenaline. And then, if we also perform the aggregation response to this thromboxane analog, U46619, this can distinguish between a defect at the level of the thromboxane synthesis from a defect at the level of the thromboxane A2 receptor. More rare are the defects at the level of one of the IDP receptor, the P2Y12 receptor. In this case, the hallmark of the platelet aggregation profiles is the reduction of a reversible response to ADP, even at very high dose. In contrast, we will have found a minor effect in the response to adrenaline and reduced response to low doses of other agonists, most notably collagen. Regarding the GP6 defects, in this case, the hallmark of the platelet aggregation is the lack of response to collagen and lack of response to CRP, and a mild reduction in the response to low dose of collagen, as collagen, as you know, binds to two different receptors, GP6 and GP1A. And if we can perform also aggregation with rhodocitine, then we can distinguish a defect in the level of GP6 or at the level of the GP6 from a defect at the level of the GP signaling, as rhodocitine that binds to CLEC2 uses exactly the same signaling pathway. And lastly, we can find also cases where we can find defects in aggregation response to agonists like PAR1, PAR4, or the thromboxane analog, and normal response to others like ADP, CRP, or PNN. Those can suggest that the defect is at the level of the GQ protein that is linked to all these seven transmembrane G-coupled receptors. So we've been using the platelet aggregation for all this year, and we essentially have followed the recommendation of the ISTX. This slide shows the panel of agonists that we are using for many years. And one thing that we have tried all these years, once we realized that a problem was to have fresh blood from some patients that live not in Murcia, is that we have tried to evaluate the aggregation response in shipped samples. collected or performed diasyn within 24 hours from collection. So, as expected, we noticed that in these non-fresh samples, we can see a significant decrease in the aggregation response to most agonists as compared to the fresh blood. But even though maybe the residual response in these samples could be enough to evaluate, to be interpreted, and to suggest at least some of these inherited platelet function disorders, especially the severe ones. So in the rest of the talk, I'm trying to give some examples on how we have been using these tests to evaluate inherited platelet function disorder without or with associated thrombocytopenia. To start, a case, in this case, a woman with normal platelet count and volume and high severe or quite severe bleeding diathesis. She has 4 daughters, 1 with bleeding. When we performed the platelet aggregation in this case, we found that it has reversible aggregation to ADP at low dose and almost normal response, also at higher dose, as combined with a lack of response to epinephrine. In contrast, we have normal response to arachidonic acids and also reduced response to low dose of collagen. Those features are exactly the ones that in the paper of Dawood suggested that can be linked to GI signaling defect. But in this case, the HTA gene panel that we have performed so far is negative. So we are planning to do whole exome sequencing in this patient. Another cases are these 2 pedigrees in which they were referred to us because of the oculocutaneous, albinis, and mild bleeding, suggesting Hermansky-Pudlett syndrome. When we performed the aggregation in this patient, we in both of them found a reduced response to different agonists, especially collagen in both cases. And in contrast, for example, in this one, the response to ADP at high dose was similar to the control. So this suggests a defect in the dense granules. And that was confirmed in both cases by performing other tests, including the expression of the release of C3063 by flow cytometry in this family, and the immunofluorescence analysis of CD63 in blood smears using immunofluorescent test, or in this one by performing the gold standard for this disease, which is the whole mount electron microscopy and seeing the sharp reduction in the dense bodies in these cases. And by performing a genetic analysis in those 2 cases, the diagnosis was confirmed by identifying, in this case, 2 different mutations in the HPS5 genes. And in this one, the panel was initially negative, but that was because this pedigree has a big duration that was detected by using nanopore sequencing. In this case, in these 2 patients, in these 2 pedigrees, we performed the platelet aggregation, and remarkably, we show an almost selective defect at the level of ADP, suggesting a defect on the P2Y12 receptor. That was also supported by the fact that both fibrinogen binding of P-selectin secretion was also impaired in response to this agonist. And when we performed the genetic analysis, we identified 2 different mutations in the P2Y12 gene, suggesting or confirming the diagnosis of P2Y12 defect. And that was confirmed also by immunoblotting in this family by seeing the lack of expression of this receptor. We also have a case, this case also referred to us by bleeding diathesis and normal platelet count, that has an almost selective lack of response to CRP, which is or reduced response to very reduced response to CRP, which is the specific agonist for GP6, and also a reduced response to collagen, while the response to other agonists was normal. And this suggests a GP6 defect. We performed the genetic analysis and found in these patients friendship in the GP6 gene, confirming the diagnosis. And this diagnosis of this study guided the characterization of this patient. And thus we can see here how the fibrinogen binding, the alpha and delta granule is reduced in response to the GP6 agonist CRP. And also we also show or confirm the reduced expression of the receptor and by flow cytometry, either standard or quantitative one, and also by immunoglobulin, as you can see in this slide. Another inherited platelet disorder, relatively new, that we contributed to characterize the first pedigrees in the world is the RAS-GRP2 defect. RAS-GRP2 is a guanylyl hexane factor that activates RAP1, and this RAP1 is the one that is the protein that allows the conformational chain of the integrin alpha-2 beta-3, facilitating the platelet aggregation. So in this 4 pedigree, the diagnosis was finally confirmed by genetic analysis that found different mutation in the RAS-GRP2 genes. But interestingly, looking at the aggregation, when we performed the aggregation in this patient, we found a reduced response to different agonists. But one thing that can be the hallmark of this defect is the having a almost normal response to activation with PMA, which is a direct activation of the protein C. Another interesting patient is this girl that was referred to us with bleeding diathesis and normal platelet count and volume. When we did platelet aggregation in this girl, we found normal responses to restosetin part 1, but a reduced response to others like ADP and collagen. And interestingly, when we did aggregation with arachidonic, we found a lack of response, suggesting a severe defect in the thromboxane A2 pathway. And in this case, the aggregation with the thromboxane analog U46619, giving a normal response, suggested that the defect was at the level of the thromboxane synthesis. And that was confirmed by observing very low level of this thromboxane in the supernatant of the platelet aggregation agent, and also in whole blood stimulated with collagen. So when we did the genetic analysis, the diagnosis was confirmed by identifying a heterozygous variant in the PTGS1 gene that affect one of the 4 glycosylation sites in the catalytic domain of the COX-1. And this leads to the presence of an abnormal COX-1 isoform in this patient. And we were also even able to express this variant in COX cells and see how these cells expressing the variant has a sharp defect in the production of thromboxane upon stimulation with arachidonic acid. So this is one of the few COX-1 deficiency that has been confirmed at genetic level reported so far in the literature. 2 interesting families are these 2 ones. Those are thrombocytopenic pedigrees, with moderate thrombocytopenia and normal platelet count that were referred to us, in this case because of the moderate bleeding diathesis. In this case, also apart from the bleeding, because of the history in the family of malignancy. So when we perform platelet aggregation in these 2 pedigrees, we noticed that the response to collagen was reduced in both cases, and also to some other agonists like epinephrine or CRP at a low level, while the response to others like ristocetin, arachidonic, or PAR1 was normal. In this disease, is known to have also a defect in dense granules in the platelets, and that could also be confirmed by doing hormone in this patient. And finally, a genetic diagnosis confirmed this RANS1 related thrombocytopenia by identifying the RANS1 pathogenic RANS1 variants in these two pedigrees. Lastly, I'd like to comment this pedigree, this last pedigree that were referred to us because some of the patients had thrombocytopenia and bleeding, but it was a complex variety of clinical symptoms, including immunity defects, recurrent infection, even thrombosis in some of them. So we performed platelet aggregation in this patient and found that in general there was a reduced response to different agonists, but of course this cannot lead to a specific diagnosis. So we did the genetic analysis in this pedigree and found that they have this gain of function variant in the SARC gene, which has been previously reported. This gain of function results in a systemic activation of the SARC, leading to phosphorylation or systematic phosphorylation of the proteins downstream of the SARC. And as I said, this variant has been previously reported in just a couple of other pedigrees. And to end my presentation, I just want to comment that artificial intelligence is here and is here to help us. And probably these new technologies will help also the interpretation of the platelet aggregation. And interestingly, at the last ISTH meeting, a group from Cambridge presented this oral communication in which they have used artificial intelligence machine learning procedures to interpret the platelet aggregation curve obtained by using a CISMET device in different centers in UK, and they perform more than 1,000 platelet aggregation studies. So by doing this or by applying this machine learning procedure, they were able to reclassify the most important data of the complex data of the platelet aggregation in a small number of data that they can be represented and provide cluster. And with that, they are able to distinguish abnormal from a normal platelet aggregation profile. And they report that this system provides high sensitivity and specificity. So in the future, even they have limitations, this new machine learning procedure can help also to automate or make easier the interpretation of the platelet aggregation studies. And with that, I think that I finished my presentation. I really like to thank you again for the kind invitation, and I'm ready to try to answer your question. Thank you very much.
Thank you very much, Professor, for your excellent presentation. It looks like we already have a couple questions in the chat, so I will go ahead and read those out loud for you. We have an encouraging comment. Great talk, Pepe. It was clear how useful the approach is in the context of inherited platelet function disorders. But what do you think about the usefulness and necessity of conducting aggregometry and IT?
Right. As I said in my presentation, the new subcommittee in platelet in biology has just made a study on that, and they will make the recommendation. The paper is being reviewed by the members of the ISTH. I'm not sure whether it has been already submitted, but they provide recommendation to do that in inherited or in the context of thrombocytopenia. Our experience is that in some of the thrombocytopenia, the aggregation it's more or less normal, let's say. No, it's not the case, for example, of the RANES1, as I said. And I think in RANES1, for example, or ETB6, it's very important to perform the platelet aggregation because that will reflect the bleeding problem that the patient have. And also in other cases where the aggregation response is thought to be normal, we have found in some of those cases some abnormalities. So, given say that, my advice is that, for example, in MY9 or other cytoskeleton-related thrombocytopenia, performing a platelet function test can be useful if the patients are going to be submitted to any kind of hemostatic challenge. Maybe the profile of the platelet aggregation will be heterogeneous, but at least we might be aware of some patients in whom the platelet function defect, even moderate, can be identified. And then we can be more prepared to manage this potential hemostatic challenge.
Great. Thank you very much for your thorough answer and for that question. We have another question. Thank you, Pepe, for the presentation. You talked about dense granules, but what about alpha granule defect? Can LTA help?
Actually, the typical, the pathognomonic example of the alpha granule defect is gray platelet syndrome. We have just a few cases of that. But the issue is that in those cases, we haven't really been able to detect defects in platelet aggregation. But anyway, if one of these cases come across to our lab, we will do it. But not only aggregation, but of course, in combination with other, maybe more specific ways to evaluate the presence of the alpha granules, including easy ones like measuring P-selectin secretion by flow cytometry, and of course, electron microscopy, which is the gold standard to demonstrate a severe defect of the alpha granules.
Great, thank you very much. We have another question. Thank you for the presentation. How do you interpret a prolonged lag time of collagen-induced aggregation?
All right. Carefully, because the collagen it's an agonist that per se has a longer lag than other agonists. That's known. It's probably also influenced by the genetic of the GP1A integrin. For example, something that we have commented in the lab many times. We in the past performed a genetic study of the HPA5 genotype in people in the lab. And I have a genotype that links to, is associated with a smaller number of this integrin in the platelets. So the lag, I finally have a normal response to collagen, but my lag is larger than the other people that has the other genotype. So if you see that, you should expect a normal, let's say, between 0 and 1 minute lag, and that might be influenced by the genetic of the integrin. But in other diseases, the lag can also be useful. For example, I remember that when we studied our patient with the RAS-GRP2 defect, that was also typical. We saw this longer lag for collagen and suggested that was due to other defect, maybe the RAS-GRP2. So depend on the lag. It happened also for example, with arachidonic acid. Sometimes we see a curve that is delayed, seems to lag to have a kind of lag. So indeed, the lag is something that we have to look at and interpret that lag, because it can also, you know, mark some kind of platelet defect.
Great, thank you once again. We have a question from one of our future speakers from, I believe, session 7, so you have to tune in for that session as well. We have a comment. Thank you, Pepe, for this excellent talk. How do you take into account the inter-individual heterogeneity in platelet aggregation among controls? For example, with epinephrine, approximately 20% of healthy controls are non-responders for 5 epinephrine.
It's true. The thing is true. And that's why we cannot use a single agonist to interpret a platelet aggregation study. That's the point. It happens. Epinephrine, for example, it's a very sensitive agonist to many analytical and pre-analytical variables. So it's one of the agonists that you can lose the response very easily. For example, not allowing blood to or the PRP to be rest before the assay, something that can influence the response. The thing is that, and we receive a lot of proposal for studying patients that are reported as having only a defect in the epinephrine response. And my answer is always the same. We need to see something more. We need to at least to use ADP and see the response to ADP as well. Epinephrine by itself, it says that it is a hallmark, for example, for the Quebec syndrome. But unfortunately, I have never evaluated a Quebec syndrome patient, so I'm not sure of that. I trust the group that mentioned that, but I will say that if you have a defect in epinephrine, you have to be careful in the interpretation and look at the response to other agonists like ADP or a low dose and see what happens.
Great, thank you. And I believe there's a question in reference to one of the earlier questions. Thank you for your great talk about dense granule defect. In what percentage would you estimate that LTA is impaired?
Difficult to answer a percentage. The thing is that you know, in almost, not all actually, but all the classical severe dense granule defect, platelet aggregation, at least to a couple of agonists at low dose, is impaired, like the Chedia-Higazi or the Helmasti. But the thing is that many other patients that would have been unable to classify, and we see mild alteration in the response to low dose agonists, we haven't really been unable to perform, for example, whole mount. So we are not sure whether those cases can also have a storage pool disease. I don't know. I cannot say a percentage.
Great, thank you very much for the question and the answer. We have another question from Paul Saultier, our collaborator and the expert who spearheaded this program. If you'd like me to read it out loud, I perfectly can, or if you'd like to read it out, feel free.
Yes, thank you, Gavin, and thank you very much, Pepe, for this lecture. So your topic was about the diagnostic value of LTA for the diagnosis of IPFD, but I wondered your opinion about the value of LTA in predicting the bleeding phenotype of the patients, for example, for children who had few hemostatic challenges. Do you value LTA in predicting the bleeding phenotype?
I will say no. That's what I will say, because I think no study has really proved a real correlation between the level of dysfunction observing LTA assays and bleeding, because bleeding is complex, depends on many other things. And the point is that I'm sure in your series of cases you might have those one as well. But we have some patients with exactly the same mutation, for example, that behave differently. And in fact, sometimes it happens that the one that has a higher ISTH-BAT score and more bleeding problems actually have the less dysfunction in the LTA, and the opposite. So I don't think we can really use LTA to predict the severity of the bleeding of the patient. It will depend on many other things. So my answer will be no.
Thank you, Pepe.
So perhaps we have time for one last question from one of our future speakers as well for session 6, Agnes. It says, thank you very much for this enriching summary. How do you explain the difference between normal results in LTA and abnormal results in flow cytometry for questions of secretion anomalies?
Can you repeat, please?
Yeah. Sorry about that. How do you explain the difference between normal results in LTA and abnormal results in flow cytometry for questions of secretion anomalies?
Yeah. Well, I think that the point is that LTA and flow cytometry are so different tests. They are not performing the same conditions. I don't know how people do the flow cytometry. That's a recommendation of that. But let's assume that LTA is performed in a standardized way in most centers. So we more or less use the same procedure. Will be not the case for flow cytometry, but even though we do LTA and PRP with a platelet concentration around 300, for example, between just above 150, while flow cytometry, we, for example, made the assays in diluted blood. There's no stirring. It's just you just mix the agonists in the tubes and are different. The contact in the platelets is much lower in the flow cytometry than in aggregometry. So something that can really be explained because of that. But honestly, I think that flow cytometry is really very useful to detect secretion defects because, for example, for p-selectin, we use a battery of agonists, and we might have a defect on one or two. But the thing is that if there is a relevant defect in the number of the content of this granule, we will see a defect in the response to a battery of agonists, and that is useful for diagnosis of this alpha, or is exactly the same for the delta granules. So.
Great. Thank you so much for your presentation. I think given the amount of questions, it's a very engaging subject, and we thank you profusely for your presentation today. I'd also like to say a special thanks to Professor Saultier, the fellow speakers that are in the audience, all the health experts, and special thank you to everyone that asked questions today. This is really the idea behind the series, is this interactive component to benefit from the expertise. So thank you once again, and we hope to see everyone on December 17th and in the upcoming webinar series as well, the sessions. Thank you so much, and have a wonderful evening.
Thank you very much. Yes.
Thank you all.